Good evening, everybody. It's actually very nice to be back in Montreal. I spent many of my formative years here, so it's nice to see some familiar faces. And I want to thank McPeak-Sirois for organizing such a wonderful evening. So you heard from Stephanie earlier, when our patients come to see us, they're expecting to get the best care. But we know there's huge variability in the patient care they receive. So where they're treating, who is treating them, what are they treated with, their involvement in their own care, and also other factors like social determinants of health and the resources that are available to them. Our patients also ask us very good questions like, am I cancer-free? Is this treatment going to work? And often we don't have the exact answers to these questions. Many times we find in clinic we are offering patients treatment which only works in 20% of patients, then we give them 6 pages worth of side effects, and we say this is the best you've got. You would often not accept that in any other situation other than, unfortunately, when you have stage 4 cancer. We also find that in our lifetime, when I do the math, I would maybe see 10,000 patients, and that would be close to retirement at that time. And we are practicing throughout that time, learning our skill. And also, I've read a study where 90% of the physicians think they're better than average, right? But when a patient comes to see us, they want to have the best doctors, the best care that they can get. So what if AI can enable you to learn from hundreds of thousands of patients? So when every patient you treat, you're synthesizing all the knowledge that's there, not just what you've learned over the limited number of patients you've seen over your lifetime. Also, only 2 to 4% of our patients make it to clinical trials. That's a very small number of patients. It's a huge missed opportunity for the patients, but also for us to learn and progress in the field. So you've heard about many different innovations in AI today, but how does it really impact care in clinic? So when it comes to screening for patients and early detection, right now it's one size fits all, as Cassie also mentioned. Average or high-risk patients getting screened very similarly for multiple different cancers, including breast cancer. But what if we are able to do high-risk patients, detect them early, do a blood test and their screening test under development, and screen those patients before they develop cancer? There's also the potential to use imaging by radiologists to look at the mammograms and predict which patients would have a higher risk of developing cancer. And many of these applications are already being used at multiple hospitals. When it comes to the diagnosis of cancers, there's the whole field of digital pathology, where by just looking at the slide, you can see which patient has an ER positivity, which has a KRAS mutation, and other things, by just looking at the slides, which can expedite care within seconds, rather than waiting weeks and weeks for patients to go on optimal care. When it comes to treatment selection, at this point, there are targeted therapy examples, but still many patients are being treated with chemotherapies, which I mentioned only work on average about 20% of the times. So are we able to use ctDNA or other examples where we can predict within weeks if a treatment is working or not, rather than exposing the patient to weeks or months of therapy with extreme toxicity? When it comes to our clinical operations, we can use AI to triage patients. You heard about Amanda, you heard about Alex, using these chatbots with patient-oriented outcomes to triage who we see in clinic. And then the clinical trials piece. There are multiple, we can talk about it for hours and hours, and multiple reasons why our clinical trial accrual is so low across the board, and this is where McPeak-Sirois comes in. I'm hoping we can use AI, better select patients, and also design better trials, so there's a trial for every patient and a patient for every trial. In the end, we also have to wear our ethical hat. These tools are only going to be as good as the data we put in it, and they have to also represent the underrepresented population to ensure equity across the board. Thank you so much.